Many thanks to the organizers for inviting me to present at this year's Bangkok HIV Symposium. I'm Todd Pollack. I'm from the Partnership for Health Advancement in Vietnam, which is a project of Harvard Medical School working in Vietnam. And I'm going to give you an overview of the management of advanced HIV disease. So for this talk, I'm going to cover the following points: the definition of advanced HIV disease, the prevention of opportunistic infections associated with advanced HIV disease, some key points about diagnosis and treatment of opportunistic infections, namely tuberculosis and cryptococcal meningitis. I'll mention a little bit about COVID-19 and people living with HIV, and finish with some ongoing barriers to implementation of the package of care for those with advanced HIV disease. So here's just to start off with a global summary of the HIV epidemic at the end of 2019. We can see in 2019, there were 1.7 million people that were newly infected with HIV and 690,000 AIDS-related deaths globally. Although AIDS-related deaths have declined by 60% since the peak in 2004 and by 39% since 2010, the reduction failed to meet the global goal of less than 500,000 deaths per year by 2020. And estimates from UNAIDS show that missing this target has resulted in 820,000 more AIDS-related deaths since 2015 than if the world was on track to meet the 2020 targets. In this slide, we see AIDS-related deaths in the Asia-Pacific region. There were 160,000 AIDS-related deaths in 2019, which makes the Asia-Pacific region the region with the second most deaths behind Eastern and Southern Africa. There were 28% fewer deaths due to AIDS-related illnesses in Asia-Pacific region since 2010. This 29% reduction is largely due to some successful testing and treatment programs in countries such as Australia, Cambodia, and Thailand that have achieved the 90-90-90 targets. However, AIDS-related mortality rates are rising in some countries in the region, such as Afghanistan, Pakistan, and the Philippines. And overall, if we look at this graph, we can see a relative plateauing of the rate of decline over time. This plateau in the decline of AIDS-related deaths globally is largely due to the persistent challenge of advanced HIV disease and its associated high mortality. Advanced HIV disease is defined as a CD4 count of less than 200 or WHO clinical stage 3 or 4 for adults and adolescents and children older than 5 years old. And all children younger than 5 years old with HIV are considered as having advanced HIV disease. Advanced HIV disease is common. It's estimated that 1 in 3 people living with HIV present to care with advanced disease. And people presenting with advanced HIV disease are at high risk of opportunistic infections and death, even after they start on antiretroviral therapy. Leading causes of mortality among adults with advanced disease globally include tuberculosis, severe bacterial infections, cryptococcal meningitis, toxoplasmosis, and pneumocystis pneumonia. Also, advanced HIV disease did not only occur in ART-naive patients. An increasing proportion of those presenting with AHD are ART experienced, having either dropped out of care or having still been on ART, but failing to suppress their HIV viral load. In 2017, to address this persistent challenge, WHO released guidelines focused on the management of advanced HIV disease. Although the data is from a few years ago, this slide shows that the proportion of people presenting with advanced disease has remained largely unchanged over time. This proportion is higher in low middle-income countries compared to high-income countries. About 30 to 40% of people living with HIV starting ART in low and middle-income settings have a CD4 cell count of less than 200 cells per millimeter squared cubed, and 20% have a CD4 cell count of less than 100. Here's more recent data from the UNAIDS Global AIDS Update in 2020, and I focus it on the Asia-Pacific region. The pale yellow bars shows the percent of patients who presented to initial care with a CD4 less than 200. We can see that many countries have nearly 50% of their patients presenting with advanced HIV disease. For example, if you look at Thailand, Vietnam, Philippines, and Indonesia, all have more than or nearly 50% of patients presenting with a CD4 count less than 200. Also, for many countries, the situation is not really improving. If you look at the boxes to the left of the graph, the orange boxes demonstrate that the trend is not improving. More than half of the countries who have data in which to compare over 2 or more years are not improving. So to address the problem of advanced HIV disease and its associated mortality, the first step, of course, is prevention. Earlier diagnosis, better linkage to care, and improved retention are needed. This includes scaling up diversified testing strategies, including lay testing and self-testing, and implementing index case testing among newly identified people living with HIV to seek and bring to care others from their networks for HIV testing and counseling. And of course, we have to address barriers to care, barriers to care access, especially stigma and discrimination. So let's talk about how to prevent opportunistic infections that are associated with advanced HIV disease. First of all, being able to identify advanced disease is crucial to ensure that people living with HIV receive proper interventions against the associated opportunistic infections. We know that up to 50% of people with advanced disease may be asymptomatic on presentation. And so the CD4 cell count testing is crucial for identifying those patients. Unfortunately, over the past years, CD4 cell count has been de-emphasized in many countries, in part because CD4 testing is no longer necessary to determine ART eligibility. In addition, the importance of CD4 monitoring was sort of lost during the scale-up of HIV viral load monitoring. In many places, including Vietnam where I work, resources for CD4 testing went directly toward viral load testing instead. So what we need is a re-emphasis on CD4 count testing at diagnosis and at re-entry to care. Point-of-care CD4 cell testing is now available, and WHO has provided guidance on the test characteristics needed for rapidly identifying people living with HIV with lower CD4 cell counts. A qualitative test that reports either greater than or lower than 200 cells may be sufficient to allow for screening and prophylaxis for opportunistic infections, and for triggering advanced HIV disease-focused differentiated service delivery. This table summarizes the WHO recommended package of care for reducing mortality and morbidity among people with advanced HIV disease. It includes recommendations for enhanced prophylaxis against tuberculosis, cryptococcal meningitis, and severe bacterial infections, point-of-care screening and diagnosis for tuberculosis, rapid antiretroviral therapy initiation, and counseling and adherence support. So let's first start with rapid ART initiation. ART is the most important intervention to prevent mortality in advanced HIV disease. WHO recommends rapid ART for all people living with HIV following a confirmed diagnosis and clinical assessment. Rapid ART here is defined as within 7 days from the day of diagnosis, and people with advanced disease should be given priority for assessment and initiation of treatment. Integrase inhibitor-based regimens are recommended as first-line therapy and may be especially important in this subgroup of patients due to their ability to rapidly decrease the HIV viral load. At the same time, this characteristic could increase the risk for IRIS, but studies to date have not shown a significantly higher rate of IRIS compared with other non-integrase-based inhibitor regimens. Nonetheless, people with advanced HIV disease require closer follow-up during the initial period of ART, when the risk of mortality is the highest. When selecting an ART regimen, there are some special considerations for patients with low CD4 cell counts or high HIV viral loads. These are summarized in the table on this slide. For example, rilpivirine and dual therapy boosted darunavir plus raltegravir should be avoided due to higher rates of virological failure in those with a CD4 count less than 200 and a viral load greater than 100,000 copies per milliliter. Now let's move on to OI prophylaxis. Firstly, I want to remind you about the reality trial, which was published in 2017, which was an open label trial conducted in Uganda, Zimbabwe, Malawi, and Kenya that enrolled HIV-infected adults and children 5 years of age or older who had not received previous ART and were starting ART with a CD4 cell count of less than 100. 1,805 patients were randomized to receive either enhanced prophylaxis or standard prophylaxis and were followed for 48 weeks. Enhanced prophylaxis included 12 weeks of isoniazid, 12 weeks of fluconazole, 5 days of azithromycin, and a single dose of albendazole. Standard prophylaxis included cotrimoxazole alone. Patients who had started the enhanced prophylaxis package at the time of ART initiation had a 27% lower rate of death at 24 weeks than those who had received standard prophylaxis. The incidence of TB was significantly lower with the enhanced prophylaxis compared with the standard prophylaxis, as was the incidence of cryptococcal disease, candidiasis, and new hospitalizations. The results of this study directly informed the WHO recommendations for management of advanced HIV disease. Based on the reality study and other previous studies, it is clear that scaling up TB preventative therapy is necessary to reduce mortality from advanced HIV disease. TB is the most common cause of death among people living with HIV worldwide, accounting for 1/3 of all HIV-related deaths. The good news is that in recent years, there was renewed political will, with commitments from the United Nations and PEPFAR to dramatically increase the number of patients who receive TB preventive therapy. As you can see in this graph from the 2020 WHO TB report, preventative treatment for tuberculosis among people living with HIV in the 65 high-burden countries has improved dramatically in recent years. However, despite this progress, gaps still remain. I show this slide to point out that the largest gains in TB preventive therapy are coming from Africa, whereas the increase in TPT in Southeast Asia and Western Pacific regions is less significant. So what are the factors contributing to these ongoing gaps? Some are listed on this slide, including a delay in rolling out the short course TPT regimens due to procurement delays related to rifapentine. For example, in Vietnam, where I work, PEPFAR planned to procure rifapentine for around 20,000 people living with HIV in 2020, but the procurement was delayed. Secondly, healthcare workers may still not fully understand the benefits of TPT. I found this to be the case, especially for patients already on ART or those with high CD4 counts. And in the busy clinic settings, counseling patients through side effects may prove difficult and result in unnecessary discontinuations. Improved systems for tracking patients, including initiation of TPT and completion rates, with reporting back to providers and managers at the site level, will help with accountability and quality improvement. Now let's move to cryptococcal meningitis. South and Southeast Asia have the second highest burden of cryptococcal meningitis among people living with HIV after sub-Saharan Africa. Here I want to highlight the Remstar trial, which was conducted in Tanzania and Zambia, where they randomized 1,999 ART-naive adults living with HIV with a CD4 count less than 200 to receive enhanced clinic-based care with a point-of-care serum cryptococcal antigen screening and preemptive antifungal treatment for those who tested CRAG positive, and additional community support compared with standard care. This intervention led to a 28% reduction in mortality among people presenting with advanced HIV disease. Mortality was 13% in the intervention arm and versus 18% in the group that received standard of care. It also led to a decreased rate of hospitalizations. So the Remstar and the reality trial have informed the WHO recommendations on screening for and preventing cryptococcal disease. I've listed those recommendations here. Screening for cryptococcal antigen followed by preemptive antifungal therapy among CRAG positive people is recommended before initiating or reinitiating ART for people living with HIV with a CD4 cell count of less than 100. This is a strong recommendation and may be considered at a CD4 cell count of less than 200. This is a conditional recommendation. When cryptococcal antigen screening is not available, fluconazole primary prophylaxis should be given to those with a CD4 cell count less than 100. Again, a strong recommendation, and may be considered at a CD4 cell count of less than 200. However, there are ongoing barriers to implementation of these recommendations as well. In the Vietnam context, we have some studies that have looked at the prevalence of cryptococcal antigen positivity, and it's about 2.7 to 4% among those with a CD4 count less than 100. The Vietnam national guidelines do follow WHO guidelines in recommending CRAG testing plus preemptive fluconazole treatment. However, CRAG testing is not readily available, and to my knowledge is not currently being performed outside of research studies. Furthermore, the current guidelines do not recommend primary fluconazole prophylaxis in the absence of CRAG testing. So a renewed effort is needed to ensure supply chain and financial payment mechanisms are in place to allow for cryptococcal screening. And guideline revisions should allow for primary fluconazole prophylaxis in the absence of such mechanisms. Moving on to severe bacterial infections. These are estimated to contribute to over 1/3 of hospitalizations of people living with HIV globally. The full impact of bacterial infections on mortality in advanced HIV disease is difficult to estimate due to a lack of diagnostic capabilities in many settings. In the reality study, bacterial infection-related mortality rates did not differ between the two study arms, between those who had the enhanced prophylaxis and the standard of care. And with concerns about antimicrobial resistance, cost, and supply chain issues, further prophylaxis beyond cotrimoxazole is not currently recommended for preventing severe bacterial infections. More studies are needed on the prevention of mortality from severe bacterial infections among people living with HIV with advanced HIV disease. Now let's talk about diagnosing and treating opportunistic infections. I'm going to focus on diagnostics for TB. More sensitive rapid TB diagnostic tests suitable for use at the primary healthcare clinic level, are needed so that people with TB can be correctly identified and promptly treated. A few studies now have looked at the use of empirical treatment of tuberculosis in all patients with low CD4 counts, such as those less than 50, but they have failed to show a mortality benefit to that approach. Therefore, scaling up implementation of point-of-care TB diagnostics for people living with HIV should be the priority now to reduce TB-related mortality. A new urine lateral flow LAM test with improved sensitivity and preserved specificity in comparison with the currently used test may soon be available and is expected to improve the diagnosis of TB among people living with HIV with advanced disease. For example, PEPFAR is anticipating the use of the point-of-care CD4 cell test, followed by the lateral flow LAM test for all patients with a CD4 cell count less than 200. For cryptococcal meningitis, I want to focus on treatment regimens, as the ACTA study published in 2018 demonstrated the effectiveness of two new regimens for induction therapy that are easier to implement in low middle income countries. 1 week of amphotericin B plus flucytosine, and 2 weeks of an all-oral regimen of flucytosine plus fluconazole. Importantly, this study shows the importance of including flucytosine in the induction phase of the treatment regimen for cryptococcal meningitis. So here I remind you of the latest guidelines from WHO published in 2018 for the treatment of cryptococcal meningitis. For the induction phase, you have the option, as I mentioned, of the 1 week amphotericin B plus flucytosine therapy, followed by 1 week of fluconazole, or 2 weeks of the all-oral regimen of fluconazole plus flucytosine. Or the third option is 2 weeks of amphotericin B plus fluconazole. Consolidation is fluconazole 800 milligrams per day for adults times 8 weeks, and maintenance is fluconazole 200 milligrams a day for adults. Now, the lack of progress on reducing mortality related to cryptococcal meningitis, despite the advances in prevention and treatment, have led for calls for a global strategy to end deaths from HIV-related cryptococcal meningitis by 2030. This commentary, published just a few weeks ago around World AIDS Day, calls for a strategy that includes access to testing for CD4 cell count and cryptococcal antigen for all patients in need, fluconazole and flucytosine in every clinic, and flucytosine and amphotericin B with laboratories able to support safe administration in every hospital. A renewed focus on cryptococcal meningitis can result in reduced mortality for patients with advanced HIV disease. Now, I just want to mention a few words about other infections that cause mortality in people living with HIV and advanced disease. I focused on tuberculosis and cryptococcal meningitis. However, other fungal diseases contribute significantly to mortality in advanced disease, depending on the local epidemiology. WHO just released new guidelines focused on histoplasma. And PCP and penicilliosis are very prevalent in some countries in our region. I don't have time to go into the details on these today. But I do want to finally mention about COVID-19 in people living with HIV, as new data is becoming available every day. The data on whether a person living with HIV is at increased risk for severe disease or death from COVID-19 is mixed. Some studies have shown a higher crude mortality among people living with HIV compared to the general population, but this increased risk seems to be driven primarily by the high burden of comorbidities in people living with HIV. However, two large cohort studies, one from South Africa, which is in a preprint form and has not yet been peer-reviewed, and one published study from the UK, demonstrate a similar, more than 2 times risk of death, even after adjusting for other factors. The South Africa study, however, showed no difference in mortality across different strata of HIV viral load and immunosuppression level. And the UK study had no data on CD4 cell counts or viral load tests in their data set. Making progress in reducing age-related deaths requires a focus on overcoming programmatic implementation challenges. We need more data to help us understand the scope of the problem within each country and each region. Countries need to prioritize the registration, procurement, and distribution of needed diagnostic tests and medications such as rifapentine and flucytosine. Implementation of the Advanced HIV Disease Package of Care requires healthcare worker training, facility readiness, and community engagement. An expansion of HIV testing, reduction of stigma and discrimination can lead to earlier HIV diagnosis and prevention of advanced disease. So to summarize, WHO recommends a package of interventions to reduce mortality and morbidity among people with advanced HIV disease. CD4 testing at baseline and at re-entry to care is important to quickly and accurately identify patients with advanced HIV disease. Patients with advanced disease should receive priority for rapid ART initiation with close counseling and follow-up, and should receive enhanced OI prophylaxis, including cotrimoxazole, TB preventive therapy, and fluconazole preemptive therapy for those who test cryptococcal antigen positive. Better point-of-care tests for TB will improve TB diagnosis and facilitate quicker linkage to treatment. Utilizing all available tools, including easier-to-use treatment regimens, can significantly reduce mortality associated with cryptococcal meningitis. And more progress is needed to prevent advanced HIV disease through earlier HIV diagnosis and so that we can raise the mean CD4 count that patients present at ART initiation. Thank you very much for your attention.